Good evening, students. Good evening, students. Please confirm if the audio and video are fine. So I welcome you all to the oral and maxillofacial surgery MDS 360 degrees live session. So as you all know, in the last session we had seen treatment of jaw cysts and tumors part 1. Today we will be seeing the part 2 and the final part of treatment of jaw cysts and tumors. So this is the second part that we will be going through today. Okay, at the end of our session we will do a few MCQs, 4 to 5 MCQs, so that you people can easily revise or judge how to attempt MCQs in the exam. So let's start our session. The first thing that we have is there were certain protocols given for treatment of tumors. There were certain protocols given for treatment of tumors, and those protocols were given by Gold, Upton, and Marks. So these three people, they gave standardized protocols for treatment of tumors. Okay. When I say standardized protocols for treatment of tumors, they gave certain surgical modalities by which you can address jaw tumors. Okay. Now let's see what are the various surgical modalities for treatment of tumors. So these particular modalities that I've written down over here were the modalities given by Gold, Upton, and Marks. Let us see. The first one is recontouring. Second one is curettage. Third one is enucleation. Fourth is resection. Under resection we have marginal resection and segmental resection, both of which we will be seeing in detail further into our session. And the fifth one is composite resection. So from our previous classes, thank you Samriddhi for confirming. So from our previous classes we have idea about curettage and enucleation. All right, rest all I'll be discussing in detail in today's session. So coming to the first modality or the first protocol, this is recontouring. Now this term is self-explanatory. What do you understand by recontouring? To reshape something. All right, to reshape something. I'll tell you in very simple terms. Suppose there is a bony overgrowth. What you can do is you can take a surgical burr, just shave off that overgrowth and restore the normal contour or curvature of the bone. So recontouring basically involves reshaping or reduction of bone to achieve normal shape or contour. This is basically what is done in recontouring. So if I have to simplify it even further, means to remove excess or to remove bony overgrowth. All right. Now this can be put to use in fibrous dysplasia. It can be put to use in removal of bony exostosis, especially removal of mandibular tori or torus palatinus. During a fabrication of dentures, when the tori or torus palatinus cause a hindrance for fabrication of prosthesis, what you can do is you can take a surgical burr and just reduce them and restore the normal contour or normal shape so that your prosthesis can fit properly without any hindrance. That was about recontouring. Now the second modality that we have is curettage. All right, what do you do in curettage? You take a simple curette and you just scrape the pathological tissue. That is blind scraping of any pathological tissue. You can do it with it is done mechanically with the help of a curette. It is just blind scraping of your lesion or your pathological tissues. So blind scraping of pathological tissue. This is basically done for non-epithelialized pathologies or pathologies which do not have a well-defined margin or which are not well encapsulated. So basically for ill-defined pathologies, diffuse pathologies which do not have proper borders. Now the next point under curettage is this can be used as an independent treatment modality or it can be used as an adjunctive procedure. So if you remember from the last session, I had told you that there is a treatment modality for cysts known as enucleation plus adjunctive procedures. Under adjunctive procedures, we had seen curettage, that is blind mechanical scraping of your pathological tissue. So it can be used as an independent modality or as an adjunctive procedure. The disadvantage is that complete removal is not ensured in curettage. You can never be sure whether complete removal of the pathology has been done by curettage or not. So this is one of the biggest disadvantages of curettage. Now where can you put curettage to use? The example is CGCG, which is your central giant cell granuloma. Central giant cell granuloma. You can use curettage. Also, please remember, if you are using curettage as an independent treatment modality, the chances of recurrence are extremely high. Okay. So the chances of recurrence, because you're not sure you've removed the entire pathology or not, and the chances of recurrence are always very high. Understood? The next we have is enucleation. We have seen enucleation in much detail in our last session. We have also seen the indications, advantages, disadvantages, the technique. So I would again suggest, please go for 5 minutes today and go back to the previous session. Just revise the enucleation part so that things get reinforced and you can recall them or remember them well. So like we all know, enucleation is done for pathologies which are having well-defined capsules or which have lining. So they are done for well encapsulated or well-defined lesions. Okay, enucleation is done for well encapsulated or well-defined lesions. Now example of some of the conditions in which you can put enucleation to use is unicystic ameloblastoma or unilocular ameloblastoma. Okay, but please remember, enucleation plus adjunctive procedures has to be given preference over marking just enucleation. So if you have both the things in your options, please mark the one which has adjunctive procedures. I have told this in the last session as well. The next example is ossifying fibroma, cemento-ossifying fibroma, and adenomatoid odontogenic tumor, that is AOT. Fine. So this is where you can use enucleation. Okay. Now, the next treatment modality is resection. Next treatment modality is resection. All right. So, what are the indications of resection? Resection is when you are removing a block of bone which contains the pathology but without actually touching the pathology. We have seen this in our last session as well. Resection is where, I'll repeat again, resection is where you are removing the pathology without actually touching the pathology. So what you're doing, you're removing the adjacent bone and while taking certain margins. So that margin is 1 to 1.5 mm. All right, you take a margin of 1 to 1.5 mm. So the indications are aggressive lesions, all right, which are highly aggressive, rapidly expanding, lesions causing destruction, rapid destruction of bony structures, such lesions are indicated for resection. Lesions showing features of local invasion, either the lesions are capable of invading the bone, invading adjacent soft tissues. All right, so such kind of lesions are highly aggressive. They tend to spread. All right, so for them the treatment will become resection. Or lesions with high rates of recurrence. So in case a lesion is inherently by nature, it tends to recur, it tends to come back again and again, so there you will utilize resection, you will go in for resection. Now this does not mean that resection will completely make the chances of recurrence zero, but it highly reduces your chances of recurrence, but does not completely eliminate the chance of recurrence. All right, when we are doing resection, we take wide margins of excision. So basically you take 1 to 1.5 centimeter all around the tumor, but if you have to answer, for answering, please always mark 1.5 over 1. Please give preference to 1.5. Okay, so you take 1.5 margins all around to get a good clearance, to make sure that you have completely removed the pathological process and nothing is left behind. So the examples are ameloblastoma, ameloblastic odontoma, odontogenic myxoma, and CEOT. Calcifying epithelial odontogenic tumor. Okay, CEOT. So these are examples for resection. Now the next thing, we have something known as composite resection. All right, now what was resection? Where resection was something in which you were not touching the pathology, but you were taking margins on the adjacent bone and removing the block of bone which contained your pathology. Okay, please listen carefully. Now comes the difference between resection and composite resection. In composite resection, you are removing the pathology along with the adjacent bony tissue as well as the soft tissue. Okay, so you are removing the pathology along with the bony and soft tissue that is present around it. So I'll just make a small diagram. Let's say this is the tumor. Okay, and this is your bone, the surrounding bone, and then comes your soft tissue. This is your surrounding soft tissue. Now what are you doing is, you will include the soft tissue in your resection. So when you are including soft tissue in your resection, it becomes composite resection. So automatically what happens, you are removing the adjacent normal tissues or adjacent uninvolved healthy tissue. Now, composite resection, let's see. It is defined as removal of pathology with wide margins of excision and removal of uninvolved adjoining or neighboring soft tissues. Alright, so these lines are very important. Removal of pathology with wide margins. Now here there is no numerical value which you assign to the margins. In resection we were removing around 1.5 to 1, alright, or 1 to 1.5. But here you just say wide margins. Wide margins. When you say wide margins, that means you are including the soft tissue. But there is no number to it, because soft tissue many a times will be beyond the distance of 1 to 1.5 centimeters. It can be farther away. So that is why we say wide margins of excision. And removal of uninvolved adjoining or neighboring soft tissue. Even though the surrounding soft tissue is uninvolved, but you will still remove it or still include it in your resection. Alright, so very important, this is indicated in malignant tumors where there is a very high chance of spread. Alright, so this is indicated in malignant tumors. For example, odontogenic myxoma, ameloblastich carcinoma, osteosarcoma, chondrosarcoma, Ewing's sarcoma. So composite resection is used for all of these treatment modalities. Apart from the odontogenic tumors, composite resection is also put to use in oral squamous cell carcinoma. Okay. Now there are certain specific terms in relation to mandible and maxilla, so we will just have a look at these specific terminologies. So let's come to the first one. So in the first slide I told you that under resection we have something known as marginal resection and segmental resection. Okay, now what is the difference between these two? So the first thing that we have here is en bloc resection, marginal resection, or resection without continuity loss. Why is it known as en bloc resection? Because we are removing a small block of bone. We are removing a small block of bone. Why is it known as marginal resection? Because we are leaving 1 to 1.5 centimeter bone at the inferior border of the mandible. Alright, we are retaining 1 to 1.5 mm of bone at the inferior border of the mandible. Alright, that is maintained as a safety margin. Why it is maintained as the safety margin, you will understand when I am drawing the diagram. Okay, and here the continuity of the lower border is maintained. The continuity of the lower border of the mandible is maintained. Now let us see with the help of a diagram. Okay, let us say this is the pathology. Okay, before we go ahead further, I just want to, with the help of this diagram, make you understand something known as a pathological fracture. Okay, let's say for example this is the pathology. I will just zoom out. Alright, let's say if this is the pathology. Okay, now there's this much of bone remaining at the end. Okay. So now after removal of the pathology, what will happen if you have enucleated or something? I'll just erase and draw in this diagram itself. We will be anyways drawing a fresh set of diagrams. So for example, you had done the enucleation. Alright, for example, you did the enucleation and you have covered this with a flap. Okay, now let me zoom out. So there is a very thin bone remaining over here. So what has happened? The pathology has weakened the jaw structure. Pathology has weakened the jaw structure. So if this small amount of bone is remaining at the inferior border, then it will lead to structural weakness. So if the patient will eat something, bite onto something due to occlusal forces, what can happen? Fracture. This can get fractured. So a bone which has been weakened by the presence of a pathology, in turn making it prone to fractures, is known as a pathological fracture. Alright, yes, in the last class when we were discussing between enucleation and marsupialization, we had come across this term pathological fracture. So this is what a pathological fracture is. Okay. Now I'll zoom out and we will have a look at marginal resection. Let's see what is a marginal resection now. Okay, so what I've drawn in blue is the pathology. Now we will take 1 to 1.5 centimeter margins all around. Okay. So you will remove 1.5 centimeter of bone all around this pathology. Fine. Now when you are removing this, go to the diagram on the next page. So this is a block of bone removed after taking your margins. Now you are left with a picture like this. So this bone here should be at least it should ideally be between 1 to 1.5 centimeters, but it should not be. It should be more than 1 centimeter. Alright, less than 1 centimeter will weaken and will cause fracture. Alright, so your block of bone, once you remove the block of bone, once you do your en bloc resection, once you do your marginal resection, you should have at least 1 centimeter bone at the inferior border. Okay, now I want you all to understand one more thing over here, which is important and which has been asked also previously. So we have removed a block of bone, but if you see, the lower border is intact. The continuity of the lower border is intact. It is maintained. There is no disruption. There is no break in the continuity of the inferior border of the mandible. So I'll write it here. Continuity of lower border of mandible is preserved or is intact. Okay, so this is another important point that you have to remember in marginal resection. The second one under resection we have is segmental resection or resection with continuity loss. So when we say a segmental resection, it means that a segment of mandible has been removed, alright, or a part of mandible has been removed, and in doing so we have disrupted or broken the continuity at the inferior border of the mandible. So the continuity of the lower border has been disrupted or it has been broken in segmental resection. So let us understand with the help of a diagram. Let us say this is our pathology here. Okay, now when you will take margins 1.5, so it will likely involve the lower border as well. Right, so you will remove this. You will remove this segment. I'm coming on to the next page. Now you will be remaining with two segments. Alright, there will be segment 1 and segment 2. And there will be no bone over here in between. Alright. So what has happened? This continuity has been lost. Alright. So continuity of lower border is disrupted. Continuity of lower border is disrupted. Alright, so I hope the difference between marginal resection and segmental resection is clear to all of you. I hope the difference is clear. If there are any doubts, you can ask me in the comment section. Now I have visuals over here showing you the difference between marginal mandibulectomy and segmental mandibulectomy. So please don't get confused. Alternatively, marginal resection is also known as marginal mandibulectomy, and segmental resection is also known as segmental mandibulectomy. Now the most important thing that I want you to see here is this is your marginal resection or en bloc resection. If you see here, a block of bone has been removed. This one is your block of bone. Okay, if you see this height at the lower border, you can easily make out that it is more than 1.5. All right, so this will retain the strength of the mandible. This will not let it fracture. So you are supposed to have a minimum of 1 centimeter at the lower border. Okay, so this should be always more than 1 centimeter, and the continuity is intact. Alright, continuity is intact. If you see in the second image for segmental mandibulectomy, this is your segment. This is your segment of mandible which has been removed. Okay, and the continuity is lost at the lower border. So this continuity has been lost. Okay, even if you will just remember the visuals, you'll be able to recall in the exam. So I always tell you in my classes as well, please try to have a pictographic memory. So, certain things you can actually just remember with help of diagrams and visuals, and you don't need to memorize the points under those topics. Fine. Now the next thing that we have is hemimandibulectomy. What is hemimandibulectomy? Hemimandibulectomy is basically removal of one half of the mandible. So either right side of the mandible complete will be removed or the left side. Okay. Okay, so let's say for example there is some pathology over here, diffuse sort of a pathology. Okay, what you'll do is you will just remove half of the mandible and you will be left with a picture like this. You will be left with a picture like this. So this is your hemimandibulectomy. Now please remember, in hemimandibulectomy also the continuation of the inferior border has been lost. Alright, so hemimandibulectomy also comes under segmental mandibulectomy because the continuity of the inferior border has been lost. Now coming to disarticulation. Disarticulation is when there is a pathology in the TM joint and you have to go and basically remove the condyle because the condyle has a pathology. So let us see. I'll draw the complete mandible so that you all can understand. Please see carefully. Suppose this is a pathology, alright, in the condyle. Now we will take our margins all around. Okay, so let's say this portion has been removed. This portion has been removed. Now what will you be left with? Let's see what you will be left with. That is, please listen carefully, this is important. So as you can see, on one side you have lost the joint, loss of joint. Loss of joint. Now I want you to notice, if you trace the inferior border of the mandible, if you trace the inferior border of the mandible from here, if you start from here and you trace it to the other condyle, you will see that the continuity of the mandible has been lost. Alright? So joint is lost, continuity of lower border lost, so this also forms a part of segmental resection, because you are losing the joint as well as losing the continuity of the mandible. So I hope this is clear. So disarticulation can also be called as a segmental resection, same like hemimandibulectomy. Okay. Now I have two small visuals where you can understand. So here it says hemimandibulectomy, right half of the mandible is resected. So if you see here, the mandible is just till here. Beyond this, there is no continuity in the mandible. Okay. Now, if you see this image, the second one, this is basically telling you about disarticulation. So if you see here, the joint is lost over here. There is no TM joint. Okay. So this becomes your disarticulation, but this also becomes segmental resection with disarticulation, because again the continuity of the lower border has been lost. In the previous one, you were directly in hemimandibulectomy, you were removing one half of the mandible, but here even if you're removing just the joint, it will be called as segmental resection, because in the condyle area your continuity of the mandible has been lost. So the posterior segment is resected, leading to loss of not only the continuity but also the condyle, known as disarticulation. So I hope this is clear. Now apart from this, here we have, those were regarding your terminologies of the mandible. Now we have certain terminologies of the maxilla. For this you don't have to go into the much details, you just have to remember the names. So partial maxillectomy is known as removal of partial maxilla, a part of maxilla. You're removing a part of maxilla in partial maxillectomy. Okay. In maxillectomy, you are removing complete maxilla. You're removing complete maxilla in maxillectomy. Now there's something known as extended maxillectomy. Extended maxillectomy. So sometimes what happens is, when you are removing the maxilla, you may remove a part of the nasal bone, you may remove a part of the temporal bone, you may remove a part of the orbital bone. So when along with maxillectomy, when you're removing adjacent bones or adjoining bones, then it is known as extended maxillectomy. That means you are going beyond the scope and boundaries of the maxilla and you are also removing the adjacent bones. So I hope this is clear to you. Now very important, we have here is incision of maxilla. The incision of maxilla is known as, for maxillectomy, is known as Weber-Ferguson incision. Okay, so Weber-Ferguson incision basically starts in the midline of the upper lip in the philtrum region. It goes till the base of the nose. Alright, it goes around the nostril, around the ala, parallel to the bridge of the nose, and then it is curved towards in your infraorbital crease, and then it goes laterally. So why this is known as incision for maxillectomy is when you reflect this incision, it gives you a open book kind of access to the maxilla. Hence, it is known as the maxillectomy incision. It's also known as a maxillectomy incision. So this is important, has been asked previously in your examinations. So, and this is the visual. Exactly how I described the incision to you, this is the visual. Visual also has been asked priorly. So please take note of this. This incision is important. Just you will be asked regarding either to name it or to identify it. Also known as maxillectomy incision. Now that is all that we have for the treatment of tumors of the jaws. Alright, I have 5 multiple choice questions for you all over here. Okay, I want this last part of the session to be interactive. Please put down your answers in the comment section, and please also mention the question number along with it. Alright, I'll read out the question to you all. I'll tell you all the 4 options. I want you to please tell me the answers in the comment section. Don't be afraid of putting out the wrong answer. This is your time where you can make mistakes, and your mistakes can be rectified by us. So please don't be hesitant. I want all of you to answer whether it is right or wrong. I am here to tell you the right answer along with the proper explanation. Okay. So starting with the first question, which of the following surgery is indicated for removal of 3 cm ameloblastoma involving the inferior border of the mandible? Option A is enucleation, B fulguration, C cryosurgery, and D resection. So I would like quickly all of you to please answer me in the comment section. I'll wait for 2 minutes. Okay. Other viewers, please tell me the answers, all of whom have joined in. Learn along with me, learn how to answer your MCQs. It will be very beneficial to all of you. Okay, I see Samriddhi, you have changed your answer. Any more answers do we have over here? Okay, now let us see. Which of the following surgery is indicated for a... So now I'll also tell you, I'll read out the question and I'll tell you how the examiners confuse you. So they have mentioned the size of the ameloblastoma, 3 mm ameloblastoma involving the inferior border of the mandible. Alright. Now let us learn how we should read our question and how we should pick up the information from the question. It is telling you the size of the ameloblastoma. Now whenever you're doing the treatment modality, alright, yes, size, when you look at the size of the lesion, yes, it matters to a certain extent, but what matters more is whether it is near the inferior border or not, whether it is involving. Here the question clear cut mentions it is involving the inferior border of the mandible. Okay, now when it is involving the inferior border of the mandible, that means the inferior border is not strong enough to sustain itself. Alright, so what you will do is you will do a resection. When you will be taking margins, you will automatically be removing the inferior border. Hence your answer is not enucleation, it is resection. Alright. Now please remember, I had also told you that enucleation you only do for unilocular or unicystic ameloblastoma. Alright. The question mentions just ameloblastoma. Since it is not mentioned unilocular or unicystic, this is definitely some other variant. Okay. So I hope this is clear. Alright. Now, coming to the next question. A 10-year-old girl comes with painless bluish swelling on the floor of the mouth. Clinical examination revealed a mucus extravasation cyst in relation to sublingual gland. What would be the correct treatment? A. Sclerosant. B. Removal of gland. C. Incision and drainage. D. Antibiotics. So please quickly let me know your answers in the comment section below. I want all of you watching to please answer in the comment section so that you can learn how to attempt your questions. And you can learn how to correlate it with your theory part as well. Okay. More answers? Yes, so the correct answer here is removal of the gland. Alright, removal of gland. This is your correct answer. Now just to explain the question, a 10-year-old girl with a painless bluish swelling floor of mouth, clinical examination revealed a mucus extravasation cyst in relation to sublingual gland. They have mentioned which gland is involved, but the classical description in the question is that of a ranula. The classical description is that of a ranula. So what is the treatment for ranula? Enucleation plus excision of involved salivary gland. Hence option B is your correct answer. Okay. Let's move on to question 3. The cyst is deroofed and the surrounding periosteum is sutured to the margins of the cyst wall in A. Decortication, B. marsupialization, C. saucerization, D. enucleation. So what would be the answer here? Please let me know your answers. Yes. If we have others watching, please put down your answers in the comment section. Yes, the correct answer is marsupialization. So basically what they've done is they have mentioned the technique of marsupialization in your question and tried and asked you to identify the procedure. Coming to question number 4. Which of the following statements is true regarding segmental mandibulectomy? Option A, block of mandible is removed without disrupting the lower border. B, part of mandible is removed which causes discontinuity of lower border. C, removing a part of mandible while leaving a very thin inferior border. And D, none of the above. So what would be the answer out here? Okay, so it is asking you about segmental mandibulectomy. So in segmental mandibulectomy, you remove a part of the mandible and you lose out on the continuity of the lower border. Hence, option B is the correct answer. Fine. Coming to the last question. A 14-year-old boy has delayed eruption of the second molar. Radiography shows a dentigerous cyst surrounding the crown of the tooth. What would be the treatment of choice? Option A, extraction of the molar. B, aspiration of the cyst. C, observe for spontaneous eruption. Expose the crown and keep it exposed. What would be the answer to this question? Let me know in the comments. Any more answers? Okay, so let us understand the question. A 14-year-old boy, so a young patient, has delayed eruption of the second molar. Delayed eruption, that means it has kind of reached its chronological age and now it is sort of beyond the chronological age. The radiograph shows a dentigerous cyst surrounding the crown of the tooth. Okay, so there is a cyst associated with the tooth. 14-year-old boy, second molar is a functional tooth. Okay, so we will try and save it. So what you will do, you will give an incision, you will remove the cyst, but you will keep the crown exposed to the oral cavity so that you can facilitate its eruption. Alright, so you give a chance to erupt. You can remove you can marsupialize the cystic lining, alright, but you will have to keep the crown exposed to the oral cavity so that it can erupt. Alright. I'll use a different colored pen. So here they were asking you the treatment of choice. Alright, they were asked you the treatment of choice. So your treatment of choice would be expose the crown and keep it exposed. So this is our answer over here. Now there can be a variation to this question. Okay, if they ask you what would be the first step in management, if instead of asking you the treatment of choice, they ask you the first step in management, then your answer will change. Your first step in management would be aspiration of the cyst. Please remember, very important point. If the question does not ask you the treatment of choice or how would you manage this, if the question asks you rather what will you do first or what would be the first step in management, so every cyst is aspirated first. Alright, before you go and do the cyst exposure or expose the cyst, you aspirate the cyst. So first step in management would be aspiration of the cyst. So there are two variants to this question. Please read carefully and answer. And somewhere I think the answer is given wrong. Please correct your answer according to what I've explained you over here. Alright. So with that, we end our sessions. If there are any doubts, please ask me. If there are any doubts, you can ask me. Okay. So I would like to inform all of you students, on our eMedicoz app, we have started dental quiz. Alright. That dental quiz is open to all, available free to all, both Android as well as iOS users. Daily you get 5 questions on the app. Okay. Please share that with your friends as well. Your friends can also download the app. The quiz is open to all, available free to all. Okay. So please spread the word. And if you like our lectures, please like the videos, subscribe to the DAMS MDS Quest channel here on YouTube. After the lectures get over, in case you have any doubts, you can put your doubts in the comment section down below. We will be answering your doubts. Alright. So I would like you to also share these lectures with your friends, with your counterparts, because these lectures are free. They're available on YouTube even after your live session ends. So you can share it with others and help others as well. And I leave you with the schedule for the upcoming few days. Thank you. Happy studying.